So, should we get started? Guys, good morning, our very tiny audience. We call this intimate, actually, not small. I'm Jason Rotoli from the University of Rochester. This is my great friend and colleague, Ivy Myers from UT Southwestern, and we're going to talk to you today about inclusion of deaf and hard of hearing individuals in emergency medicine. Sadly, we don't have any financial disclosures. So we are going to describe the current state of what it looks like to be deaf and hard of hearing in medicine, and we are going to compare and contrast that to other racial minorities in medicine. Hopefully identify some of the key barriers to why deaf medical students aren't entering the field of medicine and emergency medicine, and then maybe provide some tips or a training framework to help improve that inclusion. So I'm signing deaf and hard of hearing. So this is the sign for deaf, and this is the sign for hard of hearing. You may see that if you work with deaf signing individuals, but what I'm really asking is, what does it mean to be deaf or hard of hearing? And as you can see from this graphic, it is not a simple question. There's quite a range of identities for what it means to be deaf or hard of hearing. Ivy and I focus on this group here, which is the capital D deaf group, or the group of people who use American Sign Language. But in this presentation, we're going to be talking about these two people who still identify as being part of a deaf community, but maybe don't necessarily have the exact same identity. Another important part of this slide is that this is not a static identity or a static definition, and people can move from one of these identities to another depending on where they are in their life. An example is a deaf person who is born to hearing parents may grow up in a hearing world, may initially use only spoken language and identify with a hearing world, and then arrive at an institution or a college that provides the opportunity for learning a visual language or sign language, and they may start to drift from this person over to this person. Some may fully drift all the way over, and some may straddle both worlds. So again, the key part of this is it's a dynamic identity. And the last part that's important about this graphic is hearing impaired all the way at the end is really not something that is used to identify these groups of people. It is considered pejorative, it's not very descriptive, and this group especially does not identify as feeling impaired by their deafness. They feel empowered by it. Now, it can be used to describe your parents or your grandparents who maybe grew up hearing and have some hearing loss or presbycusis later in age. My advice would be to follow the patient's description. Whatever identity they use and term that they use, I would follow them and use that. And this graph sort of contrasts the two groups of people that we really want to focus on. Ivy and I work a lot with the deaf American Sign Language users who are on the left side. They identify with common life experiences. They see their deafness through a socio-cultural lens, and they use American Sign Language, or a signed language. In the US, it's American Sign Language, to sort of unify themselves. And then in contrast, we have this other group who predominantly belong to a hearing community. They use an oral or a spoken language. They do not use sign language, and sometimes can feel impaired by hearing loss or the deafness that they have. These two graphs show a breakdown of race and ethnicity on the left side, and then race and ethnicity of active all physicians in the US. And this data is from the AAMC in 2018, so it's a little bit dated, but it is the best that I could find. And the key takeaways from these two graphs is that Black and Hispanic people are still significantly underrepresented in medicine in terms of active physicians. White people are surprisingly equally represented, and Asians are significantly overrepresented as active physicians compared to the number in the US. We're going to transition a little bit over to the disability category. Even though deaf American Sign Language users don't consider themselves disabled, they do still legally sort of fall under this category. This information is from the United States Census Bureau in 2024, and what I want to focus on really is the ages from 18 to 64, sort of the working class age group. And what you'll notice is about 22% of people in the US have a disability or identify with having a disability. And from this physician workforce diversity textbook, there's a really great description and sort of demographic breakdown of those with disabilities in the physician workforce. And the most important part of this slide is at the very top. The total percentage of people with disabilities, active physicians, is around 3%. This might be a little bit underreported because people feel stigmatized or they're embarrassed, or maybe they haven't been even diagnosed with a disability, so this number might actually be a little bit high, but it is a significant disparity compared to the 22% of people with disabilities in the US. The reason why is really complex. There's no simple answer. Some of it may be that the disability itself prevents normal cognitive development that would prevent someone from completing the prerequisites to get into and complete medical school and residency. But I'm willing to bet that there are some other factors at play, things like fear and bias as well. And then the other important part of this slide is that of the 3%, only 10% identify as deaf or hard of hearing. So a tiny fraction of a really small population of active physicians in the US. This study done by a colleague of ours, Chris Moreland, who is a deaf signing physician. He is the program director for internal medicine at Dell Medical School and also the chief of the internal medicine. He did a study trying to provide some demographic data about deaf physicians across the US. This was snowball sampling, and he was able to identify about 90 people, 60 of which participated in the study, and about 30% of the 60 use American Sign Language. And there are two important points that I want to make about this graph itself. The first is you'll notice there are very few surgical subspecialties noted. Most of the physicians and medical students who are intending to go into specialties are all choosing primary care. So that's the first thing. The second is that emergency medicine is not on the list. There is a category under here called other, and I will tell you anecdotally from my colleagues that I know, from the colleagues that Ivy knows, there are no deaf emergency physicians practicing in the United States. And so now we need to think about the why or why not, and maybe provide some reasoning for that and a way to move past that.
Thank you, Dr. Rattoli. Again, my name is Ivy Myers. So to kind of reference what he was saying, there's no deaf ASL users in emergency medicine. And there's a lot of concerns. So when I was at the University of Rochester, we actually had the opportunity to interview a ASL primary medical student who was interested in going to emergency medicine. And Dr. Rattoli and I were obviously great advocates for this individual. However, we had to have some serious conversations with the PD, with all the other associate program directors. How are we going to do this if this is feasible? Take all the other metrics aside, right? You know, board scores, whatever. Let's talk about the logistics. You know, these are the real things that may impede barriers of saying, hey, we want this individual to come to our program, but we have a lot of questions and we don't know how to go about it. And so this is kind of a destigmatizing and clarifying misconceptions that we had in those discussions. One of them, and the first one I want to talk about, is communication. The biggest concern with someone who uses a language different than spoken English is, how are they going to communicate? How are they going to communicate with patients? How are we going to communicate with colleagues, consultants, and so forth? And the misunderstanding is that they can't communicate effectively in the emergency department. I can tell you that we've witnessed firsthand that this is just not true. We've worked with, for example, a deaf pediatric emergency medicine nurse who had an interpreter with her in our PEDS ED, and she was phenomenal. Kids loved her. She had an ASL interpreter with her at all times, and she was like, to the patients, a Disney princess who walked around and signed to everyone. And that was the benefit that she brought to the department. And everyone got used to using the interpreter, and it became like the interpreter wasn't even there. So the ability to sign to her patients actually brought benefit. When I was working with Dr. Rattoli, there was one time where we had a patient, and ASL, it's not spoken English, but it has its benefits. So you do have to change how you communicate. But being able to communicate in a very loud environment, through glass, through walls, you know, that you can see through, has been so helpful. So I was able to present a patient while Dr. Rattoli's in a doc box. I'm at the patient's bedside. I have direct visualization. He's about 20 feet away, and I'm literally giving him real-time data, asking questions back to the patient, and so forth, all like in a very loud emergency department through glass and so forth. There's a nurse that I work with currently. His name is Ben. He knows some sign language. He was 30, 40 feet away. I needed an 18 gauge, not the 22 I sent him to go get. And he was coming, and I was like, no, 18, 18. And in a loud emergency department, he knew exactly what I was saying, turned around, got the 18 gauge, and came back. So there are benefits, right? There's reasons why we use nonverbal communication. And in the emergency department, I can think of no better place to learn a little bit of sign language to get by. And so this is what a deaf individual in the emergency department can bring. This is why disability is seen as diversity, and this is why we cherish diversity, is because it brings new insights and new ways to perform. So we know that deaf individuals, we've seen it, that they communicate very well, and there's different ways to do so. Another concern was, well, are they going to be able to operate in a high-stress environment? I can't imagine being deaf and trying to apply to medical school, doing medical interviews, going through medical schools, going through clerkships. They already operate with more stress than you and I did going through our medical career. So then, to say, oh, well, they're not going to be able to handle emergency medicine because it's so stressful. The right individual will. Someone who's passionate about emergency medicine, they've gone through the trials and tribulations of getting into medical school, of graduating medical school, and so to say that, oh, maybe this is where they're going to draw the, this is where we should draw the line, it doesn't give them the benefit of the doubt of pursuing their passions.
And I'll just add, they probably even have an added layer of stress and know how to deal with it a little bit more because they've been dealing with it for their entire life in terms of navigating a hearing world.
Another concern is how do we provide accommodations in a fast-paced environment in the emergency department? Their technology is playing a huge role in this, right? So there are probably more deaf ASL users who have an MD or PhD from the ages of 25 to 35 right now than there are 35 to 80, right? So there's been an explosive pipeline of deaf scientists, of deaf physicians. We just have like 2 recently that got into medical school. So it's a small community, like we all support each other and we don't try to reinvent the wheel here, but we are seeing a huge influx of deaf individuals going into medical school. Now, like Dr. Rotoli said, that a lot of them are going into prime care. Even when I was in medical school asking my mentors at the time, hey, how do I serve the deaf population, but I really want to go into emergency medicine, they were even telling me, no, you got to go to primary care, right? And so we want to back away from that stigma of saying, no, emergency medicine is not a good fit for you. And I'm worried that is what the advice that all these deaf individuals or these deaf medical students are getting. But there's technology there. I used AI dictation the other day. Blew my mind, right? But there are just as effective, dictation to text applications on the phone. And so technology is playing a huge role in bridging this gap. And ironically, at one of my sites, I use an interpreter for half of my patient visits anyway. So what's the difference of bringing in a sign language interpreter to use ASL to English? It's really tomato, right? Another concern was accommodations are too expensive and too complicated to maintain. One of our colleagues that Dr. Rotoli brought up, Chris Moreland, who's the program director himself, he's a ASL dependent. He has a fascinating story, but real briefly, his interpreter, when he started medical school, his name's Todd Agan, started interpreting for him first year of medical school, then did the second year, then the third year, then the fourth year. Then he went to, I think, UCLA to do internal medicine residency, and Todd Agan, the interpreter, went with him. And UCLA hired him as a full, as a staff. And then he finished residency, went to UT San Antonio, and Todd Agan went with him and basically started interpreting while they doing rounds. And then went to Dell, of course. But it's so interesting to see this one interpreter, his whole career was interpreting for Chris Moreland. It still is, yeah. And so it's funny how he probably is like a physician through osmosis, right? Like he didn't have to stay up and study, but he probably knows the material. But there's it can be done. It has been done, right? It just hasn't been done in emergency medicine. Here's just some quick accommodations. ASL interpreters. Probably the best for someone who uses ASL, right? We use Spanish interpreters for our Spanish-speaking patients. But there's also, you're going to have individuals who are deaf, who may not use ASL, who are maybe English-speaking. Accommodations are going to vary from individual to individual. I have another colleague who's a deaf pediatrician. He actually applied to PEM and didn't get in. And now what he does is he does full spectrum inpatient pediatrics. He goes to resuscitations. He uses ASL, but his accommodation, he doesn't use an interpreter. You know, his staff has learned how to communicate with him, and they have their own, you know, type of language, so to speak, so they can communicate really well just by working together for such a long time. So he does full spectrum pediatrics, and he, you know, his accommodation may be different than someone else. So it's very unique. But these are CART's very popular, which can now be done pretty much by AI, which is like text to speech, and then ASL interpreters.
One other comment I'll make about that is the accommodations also will vary, just like somebody's identity will vary. And even the situation they're in may change the accommodation that someone uses. So in a large group, an ASL using person may totally rely on the interpreter and only use ASL. If they are speaking at a national presentation, some of our colleagues will voice for themselves and then use the interpreter if there are questions in the audience or something like that. So it really does vary based on the person's needs.
Yep. Myth. So phone calls, so the only way to call consultants and so forth. So how do we, that was a big discussion we had, is how do we do this? Ironically, we now message, just secure chat. That's how we admit patients now, right? That's how we consult. That's like through that. And it's funny because, you know, I would like to stipulate that if we had a deaf individual, we would have transitioned to that earlier, right? We would have used direct messaging a lot earlier. It seems to be a huge favorite now. Like the hospitals love it. I love it. All my colleagues love it. So it's like, we could put in a message and they'll get back to me when they can. I'm not sitting around waiting for a phone call and so forth.
It's faster, it's more accurate and reliable. You need to go back and check what you said to the provider, or you need to add this data to it. There's so many benefits for everybody, and it's clearly ubiquitous now.
Yeah. And then procedural skills. That was a concern, again, more of a misconception. We know an ENT physician who is deaf, and he's got better procedural skills than I do. You know, he's a surgeon, right? So, you know, there's maybe adjustments and methods on how we are going to instruct, right? So again, it goes back to the accommodations, but to say that, oh, their procedural skills aren't up to par because they can't hear, that's a stretch, right? But we again hear these misrepresentations frequently. Yeah, okay. And then there are benefits, right? Diversity, disability is a form of diversity. So if we had deaf individuals to kind of integrate into our workflow, into our operations, they could give us insights that maybe we haven't thought about before, right? Using messaging, could have done that a lot earlier. You know, having, like I was talking about, that pediatric nurse who had an interpreter, that was seen as like, you know, that's what the patients remembered. That's what the families remembered. It was like, my nurse was deaf and she was great. And then like, she got tons of like positive comments from patients just because she was unique. She stood out. There's, you know, it's possible to accommodate. We've seen this. We have colleagues that have been through it before. So for institutions to say, oh, I don't know if we can accommodate this long term, or there's fears about it, it's been done. We don't have to reinvent the wheel. We have connections. We can talk to other institutions, see how they did it, see what their pros and cons were, and then bring it back to other institutions. The issue is that, you know, it just hasn't been done in emergency medicine. And I think part of that is a mix between, it takes the right individual, right? It takes the right person to say, I have a passion for emergency medicine and I'm going to commit to it. But part of that may be due to institutional fear of how are we going to accommodate? How are we going to train them effectively and eventually graduate them? Because that is ultimately the goal. And that's a sign for benefit.
And the last thing that we want to focus on are some of the positive impacts of patient care and team dynamics. He's signing, sort of sees the opportunity or take advantage of this situation, and there are real clear opportunities here. Certainly the opportunity to demonstrate patient advocacy and direct communication with the patient. So if you have a deaf physician who can directly connect with the person across from them, they have an understanding of each other's language and culture, that's a definite benefit. Standardizing visual and written communication protocols because you have a deaf or hard of hearing individual absolutely will help reduce communication errors, which is a benefit to everybody. And then we have a real opportunity for role modeling and demonstrating our advocacy by having accommodations set up for people and diversifying our workforce, and certainly role modeling what inclusion looks like. And the last is this gives your company, your ED, your institution an opportunity to demonstrate their commitment to the ADA in a proactive way. And that's it for us.
I want to say, like, we talk about benefits. One benefit, I've like thought about this all the time. What would it be like to run a code purely in American Sign Language? Like, like
You couldn't be in the room physically with people, like they were having to develop like microphone methods for like.
Yeah.
windows, just be signing.
right, yeah. Or like, I mean, running a code, like, because you think about it, I mean, it'd be quiet, right? It wouldn't be hectic, it wouldn't be loud. I couldn't yell, can someone get an EKG, please? And then everyone's standing around doing their own job, no one's getting an EKG. I can't just sign that with no one looking at me saying, get an EKG, and think it, I mean, it has to be like direct eye contact, you get an EKG. And if they're not taking direction, they're doing what they're doing, right? So I've always wondered what it'd be like to run a code in sign language.
There
And
will
I'm-
certainly be less talking over each other, right? Because you need to focus on one person communicating at once. Yeah.
There's benefit to be had.
Yeah. Any questions, guys?
I'm just thinking about every time I've applied for medical school or residency or a medical license, there's that question about, like, do you have any disabilities that can impact your performance in the workplace or interfere with your ability to do your job? How do you advise deaf physicians, as we've said, which is not always infrequently, it's seen as a culture and an identity and not a disability, but how do you advise somebody to answer that question?
I think the question is a loaded question, and I think it's a discriminatory question, to be quite honest, but it still exists. And I understand why it exists, because people want to know, am I taking this person who is going to require accommodations, and can we work that out? So I understand why it exists, but
A lot of the applicants and people who work with are hesitant to put that. They don't even want to tell medical schools
Yeah.
or programs that they're deaf.
yeah, we know a couple of deaf physicians, some of them did not check the box, and then would just reach out to the institution afterwards and say, I communicate with American Sign Language and need to have an interpreter, or I have my own interpreter coming. And so, the medical schools or whatever get a little pissed off because they're like, oh, you didn't tell us that you were deaf. And, the question wasn't, am I deaf or not? The question was, does this disability reduce my ability to do the job? And the answer is no. So I guess ask the right question.
I have to fill that out on every faculty every 2 years. It's the same question. Does this person have any physical, limitations to perform in the work? I would honestly never even thought about checking yes on this.
Yeah.
It just doesn't. There are other things I'm worried about, not
Right.
whether I'm here or not.
Right. Yeah. So. All right, well, thanks. You guys are great. Appreciate it.